So thank you. So my talk today now is regarding device consideration, and I will go from the acute heart failure and chronic heart failure. So in these slides, it is just a summary of the key points in women experiencing cardiogenic shock as a complication of acute MI. There is a different epidemiology and higher prevalence of women presenting with cardiogenic shock as a complication of acute MI as compared with men. They are normally, as it was already said, underrepresented in all the interventional trials. Regarding the risk factor and their clinical characteristics, they normally are older, have a higher comorbidity burden as compared with their male counterpart, less history of prior acute MI, PCI or CABG, and greater variability in acute MI clinical presentation, as we have said throughout this conference, and delayed ischemic times. Treatment is different. Women less likely undergo coronary angiography, early revascularization, and also rather short-term mechanical support devices, and as we have seen also VAT. Regarding the outcomes, they have been reported to have higher in-hospital mortality and 1-year mortality rate as compared with men. Let's see then the outcomes with women with ST elevation MI. This is quite known. There is evidence coming from older study, but there is no difference also with newer study. The in-hospital death coming with women is higher. Gaps are with optimal pathways of care for women with ST elevation MI, but also the management and timing of non-culprit lesion in women with ST elevation MI multivessel disease is a big gap. Women with ST elevation MI have 2-fold higher adjusted in-hospital mortality as their male counterpart. Regarding, again, disparity in care, and specifically with patients with ST elevation MI without or with cardiogenic shock. In ST elevation MI without cardiogenic shock, however, women have fewer performance measures and less PCI, but also in ST elevation MI with cardiogenic shock, and these are data coming from large sample size where only 26% of the patients were women, women are treated less aggressively as men. So they go, even in the context of an acute MI and cardiogenic shock, they undergo less CAT, less PCI, and less implantation of short-term and durable MCS. Regarding the trends in acute MI cardiogenic shock admission by sex that are shown in these slides, the bad news is that indeed the admission for acute MI presenting with cardiogenic shock is increasing, and also the sex gap in admission is increasing. However, the good news is that mortality overall is declining and mortality gap is narrowing. This is taken from our joint EAPCI-CVC expert consensus document on the indication for percutaneous short-term ventricular assist devices that I'm going to specifically talk now, because as we have seen from the literature, there is a large underutilization of these devices in women presenting with acute or chronic heart failure. So as you know, or maybe not know, there are different short-term support devices. We do have mostly used left ventricular support devices as intra-aortic balloon pump, where most of interventional cardiologists are very familiar with, but it has been not recommended by current European Society of Cardiology guidelines because all the trials were negative. Then there is the axial flow pump, such as the Impella family, going nowadays from CP to 5.0 to 5.5, and this is going to provide a continuous axial flow from 4.0 in the CP up to 5.0 and 5.5 liter minutes in the Impella 5.5. Impella CP and 5.0 can be inserted also percutaneously. 5.5 is mostly surgical. The downside of the Impella is clearly the sheet size, because we go from 12 to 21 French size with all the risk of vascular complication, unless the operator is very well skilled and prepared to have a good access management. But the good side is the LV unloading provided by Impella. There is also tandem ART and IVAC that are not, they have very few data and they are not routinely used. And then there is the RV support by Impella again, the right, that is going to provide again a continuous axial flow, maximum 4.0 liter. The insertion is through the femoral vein. Cannula size is 22 French. The tandem ART RV Protect Duo again gives a flow of 4.0 liter insertion through femoral vein or internal jugular vein, and it's 21 and 29 French. And then clearly the VIA ECMO that give you indeed biventricular support, that you can adjust the flow and you can go up to 7 liter. It's femoral vein and femoral artery, large sheath size. The problem of VIA ECMO in the context of an acute MI complicated by cardiogenic shock is that indeed the ECMO is going to increase the afterload. So normally in this kind of patient needs to have another device to indeed do the unloading of the left ventricle. That can be an Impella left or intra-aortic balloon pump. Intra-aortic balloon pump shock trial, women with ST elevation MI experiencing cardiogenic shock are sicker. They were older, more diabetes, lower systolic blood pressure, lower diastolic blood pressure. Clearly, they were underrepresented. Only 31% of them were females. And then when we look into the outcomes, just to remind you that the trial, by the way, was a negative trial, did not demonstrate any advantage of intra-aortic balloon pump as compared with the standard of care in this patient population. However, the female patient were experiencing an higher mortality, and this was quite consistently throughout the different time points. Recently, it was published indeed in the Journal of Society of Cardiovascular Angiography Intervention, a series coming from mostly US, and this is the RECOVER-3 study design. This was a prospective multi-center post-market approval registry of acute MI and cardiogenic shock patients treated with Impella, conducted at 45 sites in US and Europe. There were 358 patients treated, but indeed female again were a minority, being only 23% of the patient. And this was a specific, sex-specific sub-study. So we already commented on the numbers of female on the overall population. Females have lower mean arterial pressure, lower hemoglobin at baseline, and these were the only significant difference between the two cohorts. Regarding procedural characteristics, female had more intra-aortic balloon pump prior to Impella implantation, so there was a delay in the usage of Impella devices, more Impella 2.5, less CP, and have a shorter duration of the support. Survival and impact of inotropes pre-Impella, the usage of inotropes were impacting on the outcomes of this patient, and this is a measure of the delay in giving MCS to this patient and try to keep them indeed on medical therapy. Regarding the impact of Impella, timing and sex, the usage indeed in the patient where Impella was used before PCI, this was to be impacting on the survival significantly in women, not significantly in men. And then as predictor of mortality in women, again, the usage, the age, the R rate at admission, creatinine, but also the prolonged use of inotropes prior to Impella were impacting and were predictors of mortality in women. Another study that was recently published comes from our national study, which is the IMPIT. IMPIT was a national registry that was conducted in Italy. I was the PI of the study. This was endorsed by Italian Society of Interventional Cardiologists. To give you an idea, there was almost more than 400 patients entering into the study. Most of the patients had an impella implanted because of cardiogenic shock. Cardiogenic shock was, in the majority of the patients, a complication of an acute coronary syndrome. So in this population, 406 patients that were enrolled in the registry, female represented only 22.4%. Again, the percentages are quite consistent in all the series that we have been observing. The indication to impella in women that were enrolled in the IMPIT registry were, in the majority of the case, cardiogenic shock. So 68% of the patients that were receiving an impella because of an acute MI complicated by cardiogenic shock. Only almost 32% indeed in high-risk PCI. High-risk PCI, by definition, in our study, were women who had low ejection fraction as a clinical indication, and on top of that, complexity of coronary artery disease. The etiology of cardiogenic shock, as we said, mostly were due to ST elevation MI, non-ST elevation MI, but we did have in the series also women that were diagnosed with MINOCA that indeed, because of the cardiogenic shock, were treated with an impella device, and this was quite interesting as a finding. Procedural characteristics, there were no significant difference overall in the characteristics of women and as compared with the men in the cardiogenic shock subgroup or in high-risk PCI. The difference was in the left main disease that were more frequently encountered in the women in high-risk PCI implanting an impella as a marker of a more complex coronary artery disease of this patient. And also LVF pre-PCI indeed was higher in women, both in cardiogenic shock as well as in the high-risk PCI. Regarding in-hospital outcome, there was no difference in in-hospital mortality, both in the cardiogenic shock group and high-risk PCI. Clearly, the numbers are very different, where 50% of mortality of women undergoing cardiogenic shock implanting an impella. But also device-related complications were not different. There was no difference in access site bleeding. And this was an important finding because in most of the cases, operators are not prone to implant an impella because they are scared to have access site complication. Indeed, this clearly demonstrates that with a careful patient selection and access site management, they are not going to have more bleeding than their male counterparts. So this should not prevent an operator to implant the devices when there is an indication. Regarding no difference in all the other outcomes that were observed in hospital. Indeed, it was quite interesting, despite the fact there is not significant, indeed there was a trend at 0.06 p-value of having less MCS escalation in women as compared with men. So again, there is in general under treatment because the escalation to a more powerful MCS was less frequently occurring when a woman was the patient. And also the impella support timing was shorter in women as compared with men in cardiogenic shock indication. 1 year follow-up, there was no difference in all causes of death, cardiac death, MI, stroke in the cardiogenic shock patient, women versus men. Indeed, there was a trend toward having a higher hospitalization for heart failure in women as compared with men in the setting of cardiogenic shock. And also there was a trend toward having less need, or at least less usage, I would say, because I think it's more appropriate, of permanent LVAD or heart transplantation in women. Only 2 women underwent heart transplantation versus 19. Regarding high-risk PCI, indeed, and it was quite important, there was a higher mortality in women cohort undergoing high-risk PCI, and this was mostly due to the higher cardiac death. The primary endpoint, again, is the combination in this registry of all cause of death, heart failure hospitalization, and need for permanent LVAD or heart transplantation, And as you see, the numbers are not significantly different in the cardiogenic shock patient, rather female or male, and no difference also in high-risk PCI, but indeed there was a difference in all-cause death in high-risk patient, women high-risk patient, as compared with male high-risk patient. Timing of implantation made a difference because it was when there was not, the timing of implantation was impacting mostly females as compared with men. And this was in cardiogenic shock group, but also in high-risk PCI. So in conclusion, in women, less frequently MCS are used both in acute and chronic heart failure. Less frequently MCS are implanted before PCI in women, and in women less frequently there is an MCS escalation. Clearly these are data that are coming from a registry. We do not have data specifically in women, but I think this is an important signal that should be further investigated. However, when MCS is implanted, there are similar rates of device-related complication compared to men, highlighting the need for timely start of MCS in all patients, regardless of sex. Thanks for your attention.